time. The disease known as long COVID was addressed on Capitol Hill, led by Senator Bernie Sanders, the Senate committee.
Here's what a scientist told a Senate hearing yesterday.
Dr. Ziyad Al-Aly, assistant professor of medicine at the Washington University School of Medicine.
The burden of long COVID, the burden of disease and disability from long COVID, when you measure it, is on par with the burden of cancer and heart disease.
So what is something you would like more people to understand about it, especially with 20 million Americans dealing with this?
That it's a multi-system disorder. If you've seen one long COVID patient, you've seen one long COVID patient. It can affect the brain, it can affect the heart, it can affect the kidneys.
What do you think is missing?
I think there is quite a bit of pandemic fatigue. I think, everybody sort of is itching to leave the pandemic behind. We can't go through a pandemic without dealing with the aftermath of the pandemic. That aftermath, that sort of the legacy of the lasting legacy of the pandemic is long COVID, and we must deal with it. We cannot bury our heads in the sand and sort of ignore reality.
Welcome to Friendly Pharmacy 5. Our guest today is Dr. Ziyad Al-Aly, a distinguished professor, nephrologist, and epidemiologist at Washington University in St. Louis. As the director of the Clinical Epidemiology Center and chief of research and education service at Veterans Affairs St. Louis Healthcare System, Dr. Al-Aly is renowned for his innovative use of big data to unravel complex medical mysteries. His pioneering studies have linked air pollution to kidney disease and revealed the global burden of diabetes caused by environmental factors, influencing discussions on the impact of pollution on non-communicable diseases. Dr. Al-Aly's groundbreaking research on proton pump inhibitors, one of the most commonly prescribed classes of medications in the world, sparked crucial dialogues among medical professionals, regulators, and the public, leading to deprescription programs to reduce overuse of these commonly prescribed medications. Today, we delve into Dr. Al-Aly's extensive body of research on the enduring health issues now encountered by millions of individuals following COVID-19 infection, otherwise known as long COVID. Dr. Al-Aly, thank you so much for joining me today.
Well, thank you for having me. Really delighted to be with you.
It's so wonderful to have you. And just for the audience to be able to get to know you a bit better, could you tell us a little bit about how you got into medicine? Did you always want to be a doctor, or is there a bit of a different story here?
No, it's actually growing up, I wanted to be a computer scientist. When I grew up, at that time it was sort of computers were new and coding was new and coding languages were new. So my parents put me in, when I was in middle school, put me in a coding camp, and then really developed like a love for coding and computer coding at that time, and wanted to become a computer scientist. And then in high school, my dad fell ill and had cancer and subsequently actually died from it. And that put me sort of really in touch with I was visiting him in the hospital and seeing how he was treated and all the care that doctors gave and really what medicine represented to people, represented hope and easing suffering. So I literally switched, and I remember my mom was saying, like, are you sure? Because you've always been telling us you wanted to be a computer scientist. Are you really sure you wanted to be a doctor and to go to medical school? And I was really very sure, very clear in my mind that this is what I wanted to do. And then subsequently in the medical school and residency, and then in practice, sort of developed passion for research, and then gravitated back to data science and coding and solving problems using data and computer analytics. So ended up sort of marrying my passion for medicine and ability to solve problems and easing suffering with also my passion for data science and coding. So that's how but initially wanted to be a computer scientist. I ended up in medical school just because my dad fell ill, and I sort of felt that I need to contribute to this field. I need to advance it, and subsequently found my way to merge both.
Wow, that's fascinating. And you have such a huge body of research already. And as I was studying for this interview, I realized that you've actually done some extensive work on proton pump inhibitors, which are medications that are commonly prescribed for GERD, acid reflux, that kind of thing. How did you get involved in that? Because as a pharmacist, we love to deprescribe these, right? And I didn't know you were one of the pioneers in raising awareness about this.
Well, thank you. That's actually thanks to the patient community. The patients were started coming back to the clinic or coming to the clinic, and they were on PPI, and they started having all these problems with kidney function and kidney disease. And so we started asking the question, like, do these drugs that are actually available over the counter in the United States and people can get them literally without prescription, are these really truly safe, and do they pose a risk to kidney problems? And so that sort of initiated our thinking about the adverse events of proton pump inhibitors. And we demonstrated, we did these very large studies at the time, and demonstrated that there is, taking PPIs or proton pump inhibitors or heartburn medications for a long period of time, increases one's risk of developing kidney disease. And then subsequently, we also found that actually, not only that, it really increases the risk of several other problems, and also increases the risk of death and cause-specific mortality. And we definitely agree that these medications, when absolutely indicated, let's say for the treatment of peptic ulcer disease or GI bleed, so those definitely save lives in these instances. But taken when unindicated or unneeded, or for a longer period of time than actually needed, might actually the risk from these medications might outweigh the benefit. And so that was one of the very early findings from the lab here that we felt is really sort of important to try to warn the public about the long-term hazards of taking proton pump inhibitors and the risk on the kidney and cause-specific and all-cause mortality.
Yeah, it is really important. And thank you for your work on that, because I think it's made a significant impact. So I wanted to know, you're a nephrologist and you're an epidemiologist doing research. And then how did you get into studying long COVID? What's the story behind this?
So this is dating back to the very early days of the pandemic. I do remember in March 2020, when sort of things started going south here in the United States and actually all over the world, we convened, literally an emergency meeting for our group here, for our lab, and wanted to deliberate about how do we respond to this. We literally saw the world in crisis. We saw sort of the United States closing down. There was a, lockdown, stores were closed, gyms were closed, people were sent home, schools were, in some instances, either closed or converted to virtual, et cetera, et cetera. So we literally saw the world in crisis here in the United States in March of 2020. So we started asking, like, how do we, as a group of scientists, a clinical epidemiologists and data scientists here at the St. Louis VA, how do we respond to this? And the answer was very, very clear and unanimous across all group members, that we identify questions that are really, really important to the nation, things that really people care about, and address them rigorously using our scientific tools and our data. And at that time, there was a lot of conversation in the United States about what COVID is. Is COVID worse than the flu? Is COVID poses the same risk as the flu, et cetera, et cetera. So our early studies focused on, trying to analyze or comparatively evaluate the risks of death and hospitalization from COVID versus the flu. And so that was sort of the early thing to try to literally understand COVID better, because COVID was this new thing new kid on the block, or new thing on the block. And then, that sort of immersed us in the world of COVID and trying to understand what COVID is. And I do remember in April of 2020, we started getting reports from patients, the early wave of people who were infected with SARS-CoV-2, saying that we were previously young, we were previously healthy, we did not have any medical problems prior to SARS-CoV-2 infection or COVID-19. We got it several weeks ago. Now, weeks later, we're still having persistent problems. We have brain fog, we have this fatigue that's unexplained at the time. We have all these like weird symptoms, and we don't really know what that is, but we know that's not us, And really, I think the index case here really, and I credit her for really sort of stimulating our interest in thinking about long COVID, is an op-ed piece by Fiona Lowenstein in the New York Times. And basically, she said, we need to talk about what coronavirus recoveries look like. At the time, everybody was telling the world that if you're young and healthy, you don't really need to bother much with COVID. If you're young and healthy, you get it, you'll bounce back as if nothing had happened. But she was 26 at the time, 26 years old, previously healthy, got COVID-19. That was not her story. So that generated really that op-ed piece generated sort of a deluge of responses from a lot of responses from the patient community saying, that's my story too. I'm like you too. I was young and healthy. I had no medical problems before COVID-19. Weeks later now, after getting infected, I have these problems. So that started sort of stimulating us to sort of start thinking about what's going on here. And fast forward a month later, there was a report that was published by the Patient-Led Research Collaborative, what we call now the Patient-Led Research Collaborative, surveying their members. It's an online survey of their membership, cataloging about 200 symptoms of problems that these patients were experiencing. And around the same time, people were, started to use the term long COVID or the term long COVID was coined to encapsulate or to describe this new phenomenon. And people started, or long haulers, or people who are afflicted with these problems started referring to themselves as long haulers. So then we really, that was sort of then the thing that okay, this is we need to think about this, we need to study this, we need to understand what these people are complaining about, and to gain a deeper understanding of the problem. And that sort of launched us on a trajectory to understand what long COVID is and characterize the epidemiology of long COVID, the risk factors, effective vaccination, et cetera, et cetera.
It's fascinating, and it's so unique that the patients were the ones that really raised the awareness about this, right?
Absolutely. I definitely credit enormously grateful to the patient community. I think this is the listeners or audience, can take one thing from this. Is really the patients who actually inspired us to pursue this. Had it not been for the patient community, had it not been for their really that clarity, that they communicated, their findings to the world, that in form of an op-ed piece and subsequently a report of 600 people, a survey of their membership cataloging the breadth of organ dysfunction or breadth of problems that they are experiencing, we would not have been even able to think about what long COVID is. And also, even the term long COVID was not coined by the NIH, was not coined by the CDC or the WHO or any scientific organization in the world, was actually coined by the patient community. So this is a disease that the patient community first reported, the patient community first named, and they've been really leading the way in helping us to understand what long COVID is. So I think this is really one of the main historical or defining moments of the pandemic, that the patients led the way in helping us or guiding us to orient us to study here, study this. This is really important. People were told they were going to be fine, but they're not fine. Something is wrong here that we need to all sort of pitch in and study and understand.
Mm-hmm. It's incredible patient advocacy, especially when you think about what these people are suffering. Many of them can't even get out of bed, right? Their energy is extremely low. So for them to be able to advocate.
That's what stimulates me. That's what drives me. People say oh my God, you guys do a lot. You must be sort of driven or like a machine, or what drives me is really these patients. And I see people from PLRC and other groups who are, sick and tired, some of them with fatigue, brain fog, other problems, yet they get out of bed and they advocate and they spread the word and do all this amazing research. So I say to myself, if these people could do it, I could do it. If these people can work while sick, I to try to move the ball forward and help everyone around them and help promote understanding of long COVID and the message of long COVID, the public understanding of long COVID, then I could also, I need to do my part in helping out. And that's sort of what stimulates me. People say, oh, you guys are work too much, or I don't know, but I think that what stimulates us is this really drive, is again, is really the kudos to the patient community. If there's one thing you take from this, is really patients defined the field, and patients really helped us and help orient us to where to look and how to sort of and shape sort of the research agenda. That's very, very, very important.
Absolutely. And can you give us an idea of how big of a problem do you think this is? So we still have people getting infected from COVID-19 every day. How many people do you estimate are affected by this? Because I know there's many who are still undiagnosed. Do you have any estimates on this?
So we think in the United States there are at least 20 million Americans who have long COVID, and that estimate is likely growing because very few people actually fully recover from long COVID, and a lot of people actually get long COVID after a second infection or a third infection or fourth infection upon reinfection. So that number is going to continue to grow, and similarly there's likely also a significant percentage in Canada and in Europe and elsewhere. It's not really this is not a uniquely American phenomenon or North American phenomenon. This is really a worldwide phenomenon, and we think at least in the United States there are 20 million people with long COVID, and if you really tally it up, we're doing some work to sort of now come up with a number for the global burden of long COVID, but we think it's really significant and likely to continue to grow precisely because there's no treatment, there's no cure, so people are actually, and spontaneous recovery is really rare, and the fact that people continue to get long COVID even after reinfection.
Mm-hmm. It's a massive, massive problem, and that's why we're doing this interview today. Can you give us, do we have yet a formal definition of long COVID, or how would you define it from your research?
So there are several definitions of long COVID, but I don't think they really do it justice. There is a WHO definition. I think the main problem with it is it's really the diagnosis. It makes long COVID a diagnosis of exclusion, and Australia doesn't include all the set of abnormalities that can actually happen in long COVID. Having said that, there are definitions, and various organizations have definitions. NIH and the CDC, US CDC, and others have their own definitions. The way I like to think about it, I think sort of the long COVID is really represent the umbrella or the umbrella term for all inclusive, all the post-acute and long-term health problems that are causally driven by SARS-CoV-2 infection. So let's say if somebody got SARS-CoV-2 infection, and normally if without an infection they were not going to get a heart attack, and they get now a heart attack, that's really one of the consequences or the causal consequences of SARS-CoV-2 infection, and should be accounted for under the umbrella term long COVID. I have to think that one of the major, challenges in the field now is the lack of consensus about terms and definitions, and I definitely think that there is a certainly a need to coalesce or to develop consensus around terms and definition, and it's unlikely that one definition is going to be good for all applications. They're likely to be that one definition is sort of a clinical definition, and other definitions that may have to be developed or optimized for surveillance and epidemiology. So that's going to require its own definition for surveillance and epidemiology, and then maybe also like research definitions, right? So it's unlikely that one definition is going to fit all purposes, right? So and we have to be, it's very important that definitions have also to be inclusive in the sense that doesn't really, so it includes all the set of problems that people can encounter with long COVID. So it should be inclusive, and it should be, there should be several different definitions that could, for specific use cases, clinical, epidemiologic, and surveillance, and research. So there is a need, and I hope that there is I hope that we sort of move in a direction where we build consensus on those terms and definitions, because I think that's really one of the major challenges that arguably is delaying investment in clinical trials and delaying real solutions, because people or trialists will say, one of their excuses will say, well, like, there's no really universally agreed upon definition of long COVID. How do we enroll people? How do we define long COVID? How do we define entry criteria or inclusion criteria into trials? The other chagrin and or the other sort of a complaint or the challenge that they described to us is like, oh, well, there's really also no universally agreed upon clinical endpoints. For example, like let's say if you do an RCT for heart disease, it's very well recognized that people will do less MACE outcome or major adverse cardiovascular event, right? Very well recognized outcome. Almost everyone agrees that this is a good outcome to study, and it could be a 3-point MACE or a 4-point MACE. But generally, most societies, most regulators, FDA, most pharma, I agree that MACE is a reasonable outcome, or a major adverse cardiovascular event is a reasonable outcome when you're studying, let's say, cardiovascular or doing an RCT for cardiovascular outcomes, right? There is nothing like that for long COVID. Let's say, for example, what would be, if you enroll people with brain fog, what would be the acceptable endpoint? Would a scale demonstrating improvement in cognitive function suffice? Would a scale need to be accompanied by neuroimaging? What would suffice, or what would be acceptable to regulators then to demonstrate, let's say, for example, that drug A ameliorates brain fog versus drug B, right? So, so defining those clinical endpoints and agreeing that, okay, we're going to all use this scale because it's really good, and then maybe supplemented by neuroimaging or EEG or whatever sort of that, right? So define those endpoints and developing some consensus around those endpoints, I think, is really important to help me move the field forward.
Mm-hmm. And it's such a complex condition. I remember you saying, it encompasses over 200 symptoms, and that COVID-19 infection can affect every body system, and that we're finding the virus, in all the tissues of the body. When you started studying this, I think you started studying it for the cardiovascular impacts, but was this surprising to you to see that this is actually impacting multiple body systems?
Yes, I do remember our early study, like our first study when we did an unbiased approach looking at, the post-acute sequelae of SARS-CoV-2, and we saw hits in nearly every organ system. I do remember initially telling my team here, this cannot be true. It cannot be true. How can one virus do all of this mayhem throughout the body? Let's go back to the drawing board. Let's redesign, rethink this approach, like recheck the code, redo the analysis, rerun the experiment. And I kept saying, like this cannot be true. How can this be happening? I was a skeptic, and I told my team we have to repeat it. We repeated everything, came back the same thing. It hits almost every organ system. There were hits in the kidneys, there were hits in the cardiovascular system, in the brain. So this cannot be true. Let's do it again. And we kept doing it. We kept doing it and doing it and doing it, and kept coming back with the same exact thing. This is the data. This is the virus is doing this to people. So it was jarring initially, and I even told the New York Times it was jarring. Like I couldn't really wrap my head around it because I was it was like, how can this be? And when the R in SARS is for respiratory. Like I was like, okay, well, this is a respiratory virus. Oh, this is what we were told, and even it's in the name. We were told this is a respiratory virus, right? And it's even in the name. And it was like, but then it's hitting the kidney, and it's the heart and the brain, and it's like, I thought like something wrong in our data. I thought something is not right here. Like we have to repeat it several times. It came back the same thing, and now it's been reproduced by a lot of data in the UK and Germany, and several other places in the US. So universally reproduced that long COVID can affect nearly every organ system. Now, reflecting back on it, we learned our lesson in this pandemic that viruses, even though initially could lead to acute quote unquote acute infections, and maybe initially present with respiratory problems, can lead to multisystemic effects. Went back in the history books and read about the flu of 1918, went back in the history books and sort of read about some of the stuff that EBV does, and other viruses. It's very, very clear that viruses were in their wake were leaving us with all of this chronic disease. But we as a medical community, as scientists, and even as medical historians, failed to connect the dots. And now, hindsight is always 20/20. So now it's easy for me, go back and it's like, oh yeah, that was in, Laura, that was in the books in about 1918 pandemic. That was in, so it's very easy now to do that. But it was there all along. This is not a new thing that acute infections can yield or lead to chronic disease. It just we failed to connect the dots for the past 100 years. The clues were all there, actually starting from the Spanish flu pandemic of 1918.
Yeah, and now the problem is so big. I mean, we cannot ignore this, right? We have to deal with it.
I think that's really exactly right. So this is a significant problem of literally pandemic proportions. When people like before the pandemic, oh, this is of a pandemic proportion, like they would be exaggerating. This is no exact. This is of pandemic proportions. You know, there is no like this is not an exaggeration. This is a reality. This is a pandemic that produced in its wake millions of people suffering from chronic disease and some of them disabled in the United States, many more around the world, with really no recovery, no prospect for spontaneous recovery, and no cure, and with evidence suggesting that reinfection, which is now the common form of COVID, the common form of COVID infection, is contributing additional cases of long COVID. So the burden of long COVID is only going to increase over time.
Yeah, here in Canada, Statistics Canada released a report, I believe it was over the summer, saying that by your third infection, your risk of long COVID is probably as high as about 38%. So have you seen that in your research as well?
Yeah, we worry about that. So we've done some work also, like trying to understand the effect of reinfection, and very clearly, reinfection contributes additional risk. So I tell people that even if you've been vaccinated, even if you had prior infection with COVID, you're not totally immune from long COVID. You can get long COVID after a second infection, after third infection. And true to that, now you go to the clinic here and you see, actually quite a bit of the long COVID patients that, oh, I had COVID the first time, like maybe 2 years ago, did fine, had no problems. Had it the second time, did fine, had no problems. Had it the third time, and boom, now I'm like, my body is different. I have this fatigue, my joints ache, etc. This was quintessential long COVID thing. That person had no problem after the first infection, no problems whatsoever after the second, only after the third. So clearly we see it in the clinic. Clearly we see it in the data in the U.S. and in several other countries. I mean, as you mentioned, also the report from the Statistics Canada, showing the same thing, that reinfection contribute additional risk. What does that really mean to people? It means that 2 infections are worse than 1. That is actually still helpful if you can to reduce your risk of reinfection, because you may be one of those people who may have dodged the bullet the first time and maybe dodged the bullet the second time, but doesn't really mean you're gonna keep dodging the bullet every single time. You may, it may catch up with you, and at some point in time, you may also be, become one of those long COVID patients. I think what's really challenging about long COVID is, again, there's no curative treatment. So it's a disease that could be in some cases profoundly disabling without treatment.
Yeah, and I think this is so important because this is a message that I don't think has been communicated very well by public health. There seems to be just this general acceptance of, well, everyone's going to get infected. There's even the discussion about hybrid immunity. Well, if you're vaccinated, maybe it's good to get infected because maybe you have better immunity after that. And I don't think that's based on science. Have you?
No, this is really all foolish thinking. This is all outdated thinking, sort of, 18th century thinking that you I don't know, just very outdated way of thinking about the immune system, about immunology and how viruses interact with the human host. And so the fact is that infections can have deleterious consequences, and yes, some people emerge unscathed, and we see a lot of people around us who have COVID and bounce back and as if nothing had happened. But if you're one of the unlucky people who actually get long COVID, that's really a serious problem. And the best way to prevent long COVID, we know, is to prevent COVID in the first place. But I definitely also understand that the global mood, is one that we want to move on from the pandemic, that we want to, it's almost like this traumatic event that happened to all of us. It's really almost like a dealing with trauma. And a lot of people, when they deal with trauma, they sort of put it in this small box in the back of their head, and then don't want to revisit it, right? And move on as if nothing has happened. And I think that's really what sort of characterizes the public mood, or the public but both in the US, in North America, and Europe, elsewhere, in Australia and New Zealand, and nearly everywhere in the world. This is sort of the thinking, and And it's more like a trauma response, maybe a collective trauma response, that we went through this horrible pandemic, and we really, really are itching to move on and put it behind us. And that's understandable, because really it's a horrible pandemic, and who wants to, deal with COVID and talk about COVID and think about COVID? But the reality is that COVID is still here. Is still circulating abundantly in the population, is still infecting tons of people, is still putting people in the hospital, is still making people die at a higher rate than the flu, and is still producing long COVID. Those are all facts. Those are all realities, And yes, we wish COVID is not here, and we want to forget about the pandemic and move on and put it behind us. I understand that, but the reality is, the truth is, and I know the truth is uncomfortable and is inconvenient for many, many, many people, especially politicians. It's inconvenient to tell the public that COVID is still here with us, it's still circulating abundantly, it's still killing people, it's still putting people in the hospital, and it's still putting people, or making people have long COVID. Again, a disease that could be debilitating, that has no curative treatment, zero curative treatment. So those are the realities, and it's uncomfortable to say, and people don't want to deal with it, but that's the reality that's exactly what's happening these days.
Yeah, it is uncomfortable, but it is what's happening. It is, like you said, the reality that we are dealing with. And I know that there are other consequences of infection. One of the things that stood out to me from your research was the kidney function, reduced kidney function after each infection. So, and how this ages the kidneys. I think that's how you explained it. Could you explain that to us just quickly for people to understand?
So we looked at about 80,000 people who had been infected with SARS-CoV-2 and followed them for a year to see what happens to their kidney function after they have an infection with SARS-CoV-2. And sure enough, what we saw that compared to people who are uninfected at the time, compared to their peers who did not have a SARS-CoV-2 infection or did not have COVID-19, people who had COVID-19 had a decline in kidney function in the year that followed the initial infection. And how much that decline was? That decline was about 4 milliliter per minute in that year. What does that really mean? That really is a decline of kidney function that is commensurate with about 4 years of aging. That means that these people's kidneys aged 4 years in the span of just one. So you can, we started sort of thinking here about COVID infection as a form of that accelerated aging, as COVID sort of ages you, and you maybe your chronologic age may be X, but your biologic age now, because of long COVID, or because of having infection or maybe repeated infection with long COVID, is X plus many years. And in that study was at least 4 years aging of kidney function. And that's really so and on the surface these people would look fine, like this slight decline in kidney function, but instead of like let's say that person being 40, now they're like 44 biologically. Their kidney is behaving as that that Tim is actually now 44, and Juliet is, instead of she's being 30, now she's 34, and Henriette or Paula, instead of being 60, now 64, right? So. And that's really the cost that you pay with infection. That a lot of times, it's invisible to the naked eye. It's invisible. You look at Paula, you look at Henry, you look at Tim, well, they look fine. You examine their kidneys, they're 4 years older than where they should have been, had it not been for SARS-CoV-2 infection. Again, that's what's really, a little bit challenging about COVID is that, and long COVID, is that a lot of the stuff that it does is really invisible, or sometimes very subtle, that you don't immediately realize its implications. Very subtle cognitive problems, very subtle heart problems, very subtle kidney changes. But then you evaluate it over time. It's like, oh my Lord, this is really quite the thing. So I think that's one of the challenges of dealing with this. But it's very, very clear that one way to think about COVID infection, and is especially COVID and repeated COVID infection, is a form of accelerated aging, and that can literally affect nearly every organ system. There is another paper, not from our lab, but from another group, that was published about a year ago. They did the same thing with the brain, and they saw that after infection, these patients had changes in their brain that are actually equivalent to about, these people had mild to moderate COVID-19, not severe COVID-19, mild, most of them mild, and some of them moderate COVID-19, they had changes in the brain that are commensurate to about 7 years of healthy aging. So that again, like, Paula and Tim, they walk around, they think that their brains are 40 years old, 40, but they're 47. They're literally, their brains, or the structure of their brain is almost, after infection with COVID, is now 47, although their chronologic age may be 40. So I think that's really the price that we pay as a society for ignoring COVID and for, trivializing it and for normalizing repeated infection. And I think that sort of broadly, speaks to our collective failure of dealing with it in a better way. And it was I think one of the pieces by Ed Yong, like a while ago, maybe a year or and a half ago, like, was said like failure breeds fatalism. This fatalistic attitude that, bring it on, and COVID is a nothing burger, and yes, it's okay, but that, 150,000 people die every year from COVID in the United States. We normalize these things, and we normalize 20 million, people with COVID, with long COVID. We normalize this as if this is really, really acceptable. I think this is sort of primarily is fatalism that's most likely driven by our collective failure of dealing with it in a better way. And that's really what sort of breeds this fatalistic attitude. That's let it rip. It's fine for people to die. It's fine for people to get sick. It's fine for people to have cognitive problems and serious difficulty with cognitive issues. It's fine for people to have kidney problems, to have heart attacks, et cetera, et cetera. So that's really more like the collective failure of how we dealt as a pandemic, not only in the US, not only in Canada, but really globally. Sort of we all, I think, get a D-, maybe even an F.
Yeah, it's unfortunately, it's said a lot about public health, I guess, and how we need to evolve, and communication, the importance of communication, and the impact of a lack of communication as well. So I wanted to just quickly touch on, I know there's been some research as far as the microbiome and long COVID. We've seen persistence of the virus in the gut. What are your thoughts on this?
Well, those are leading hypotheses. A lot of people are asking, like, listening to this interview, asking, like, so why does long COVID happen? What's sort of the genesis of long COVID? One of the leading hypotheses is that, in some people, they're not able to fully clear the virus. So either the whole virus, which may be able to fully replicate and reproduce itself, or make copies of itself, or remnants of the virus, like RNA or protein of the virus, reside or remain or persist, in so-called immune privileged sites. And this sort of these serve as viral reservoirs, so to speak, that would provoke then low-grade inflammation and subsequent tissue injury and organ dysfunction. This is one of the leading hypotheses. It's really, again, predicated on the premise that the immune system may not be able to fully clear the virus. Normally we should be able to fully, you get SARS-CoV-2 infection, you should, within days, maybe even like a week or two, fully clear the virus from the body, right? But there are clear evidence of virus remaining in the body of people several months out after infection, in multiple sites, including not only the lungs, but also the coronary arteries, the heart, the brain, and multiple other extrapulmonary sites, outside the lung. And a lot of people sort of advocate for this hypothesis as potentially key to explaining why some people get long COVID. The other hypothesis has to do with something called microbiome dysbiosis. The idea that within us, there are actually more bacterial cells than human cells. And again, this is sort of like we're human-centric. We tend to think of ourselves as humans, walking around as humans. But within each one of us, there's actually a multitude of literally, more bacterial cells than human cells. And the idea is that when we get sick, actually the bacterial cell within us, which again outnumber the human cells, also get sick. And maybe they don't recover so well after getting hit with SARS-CoV-2. And maybe their sickness, they're living within us, they're sick and nagging us and nagging our intestine and our immune, and have a very, intimate relationship with our immune system. Maybe their sickness also is affecting our homeostasis, and also inducing disease. That's also a promising hypothesis. There was a recent RCT, a randomized controlled trial of with people actually given pills to restore microbiome health, and actually did better, had actually amelioration of some of the symptomatology of long COVID. There was really the first RCT actually to show some evidence of improvement in the symptomatology of long COVID, suggesting that maybe actually there's something, that maybe this microbiome hypothesis, actually maybe there's some truth to it. There are other hypotheses, revolving primarily about dysfunctional immune response, that the immune system is sort of dysfunctional in responding to long COVID, or to SARS-CoV-2 infection in the first place, and start producing excessively or exaggerated antibody responses against SARS-CoV-2 itself, reactivates other dormant viruses like EBV or Epstein-Barr virus and varicella zoster viruses, and then sort of and then you have sort of a discoordinated or uncoordinated immune response, or especially crosstalk between humoral and adaptive innate and adaptive immunity, and also exhausted T cells. So there's sort of a body of evidence suggesting immune dysfunction as the driving mechanisms of some of the manifestations of long COVID. So these hypotheses are not mutually exclusive. Or there is a fourth one about mitochondrial dysfunction, within each human cell, there's mitochondria. These are kind of, you can think of them as almost like the generators that power human life, right? Human life is sort of powered by ATP, and these are by sort of by energy that's literally produced in these mitochondria. And if your generator is out of service or is not doing so well, you're not going to do so well. And then, you're going to have fatigue and post-exertional malaise and some of the cardinal manifestations of long COVID. So those hypotheses are not mutually exclusive. Actually, several of them could be at play in any individual patient, and they may produce various symptomatology. For example, the gut neuroendocrine dysfunction due to microbiome dysbiosis may explain brain fog. The mitochondrial dysfunction might explain fatigue and PEM or post-exertional malaise. And people can have these things. People can have brain fog and at the same time have fatigue and PEM or post-exertional malaise. So these hypotheses, they're not mutually exclusive. I think I'm glad that there's a lot of work, here and elsewhere to sort of, think more deeply about these things and try to flesh them out and help us, most importantly, leverage the understanding or the evolved understanding to sort of develop more trials and to more therapeutically ameliorate symptoms of long COVID.
Yeah, and I know part of your advocacy has been because you really need funding for this research. You need randomized controlled trials to be able to not only study long COVID, but study treatments for long COVID. And so do you have right now, I know that there's been talk about different things like metformin, low dose naltrexone and things like that, anecdotally, right? But you really do need RCTs for these. However, in your experience, have you seen anything promising from any of these medications so far that you can share with us?
So anecdotally, yes, but I sort of hesitate to sort of share or endorse one thing over another because as you said, Lindsay, there is really no RCTs to help us evaluate, are these anecdotal observations really truly a reflection of some maybe patient characteristics here in the clinic, or are they really more generalizable? I think the fact that I cannot really answer this question very, very definitively or projecting uncertainty about the answer, like what is like is really telling. We actually have zero clinical randomized control trials to really help guide us, except for that single RCT for that microbiome thing, which is available in Hong Kong. It's not even available in the United States or Canada yet. There's really no treatment here that is validated by trials. And I think this really needs to change. So it's very, very important that this really changes. And the only way to change this is to do more trials with the scale and urgency of the problem. So that matches the scale and urgency of the problem.
Yeah. Another thing I wanted to touch on was Paxlovid. So Paxlovid is difficult to get in a lot of places here in Canada. It's being reserved for people who are more vulnerable or the elderly. Do you think that we need to improve access to Paxlovid for people who have COVID-19 infection? I mean, it has to be taken within the first 5 days of infection. Would that make a difference? Have you seen that in your
We
work?
think Paxlovid, so there are so Paxlovid in the acute phase in people who have risk factors for progression to severe COVID-19 illness, be it age, or they could be young, but if they have diabetes, obesity, lung disease, and kidney disease, et cetera. In this subset of patients, Paxlovid reduces the risk of severe COVID-19, reduces the risk of hospitalization and death in the acute phase in the first 30 days, and reduces the risk of long COVID. Now, you're asking whether Paxlovid should also be made available to people who are at low risk. I think, unfortunately, we don't really have very good data in that department. So in that area, possibly yes, but I think this is also an area that really needs more careful examination. From our perspective, when we studied it in people who have, we studied people who had taken Paxlovid in the acute phase, basically qualified for Paxlovid in the United States for their COVID-19 illness, and took it within 5 days, they actually displayed less risk of long COVID. And that's corroborated by other studies done on Paxlovid, and also a Japanese study done on another antiviral called enceltravir. So it's very clearly that if you hit the virus early on and nip it in the bud, metaphorically speaking, sort of nip it in the bud, or hit the virus early and hard early on with antivirals, you may reduce the risk of long COVID later on.
How concerned are you about the impact of allowing this virus to just spread on our healthcare systems that are already under so much stress?
I think, I'm very concerned, but I also think that we surrendered to it. I think we lost the fight against the virus, and I think we almost normalized its existence, and we normalized that this pandemic is here, and we're let our guards down and accepted defeat and accepted the price that we're going to pay. So the question is what is the price is going to pay? It's going to rise in the burden of non-communicable diseases as a result of this, rise in the burden of long COVID and all associated conditions, be it heart disease, kidney problems, neurologic dysfunction, et cetera. That's all going to be to materialize again as a price that we have to pay. After the pandemic, we already surrendered to it. So I think that's really most of the people around the world already surrendered to this virus and accepted defeat, and that's sort of that failure, again, to go back to that wonderful quote from Ed Young, sort of brings with it this fatalism, so things are going to happen and we're just going to have to accept it. So there are going to be significant costs to the economy. These things these things will reflect in the labor market. There's already at least 4 million Americans who are out of work because of long COVID, and that number is projected to continue to grow. And those are going to also, be also reflective of the healthcare costs. There are, significant healthcare costs projected as a result of long COVID in the U.S. economy and elsewhere in the world. And those will affect healthcare systems, because a healthcare system will have to deal with this. We'll have to deal with the rise of people with cognitive problems and brain fog and fatigue and all the other manifestations of long COVID, including all the organ dysfunctions in the kidney, in the brain, and the heart. And that will strain healthcare systems and will add to the to the cost. So I think we will continue to sort of reap or endure the cost of this pandemic for probably decades to come. It's very, very clear in my mind, but I think we also normalize it to the point that we're numb to it. So what? People, 150,000 people dying every year from COVID-19 in the United States, and nobody flinches when I actually say these numbers. They should be sad, sorrow, shocked, why is this really allowed to happen? But we normalized it. This is happening. These are the numbers. This is true. And we normalize it. So I think we just normalize the suffering and human suffering, the loss of life and economic losses and effects of healthcare systems. And that's really is inconvenient, but it's really true. That's really exactly what's happening. And sort of the rising tide of misery is going to lift all boats. So literally every segment or every facet of our life will be affected by this, economy, workplace, labor participation, societal well-being, healthcare systems, educational attainment of kids, their ability to compete in exams, schools. Literally every facet of our lives will be affected by this, precisely because COVID and long COVID are so pervasive, and long COVID affect literally every organ system, including the brain and the heart, et cetera, et cetera. So that rising tide of misery will literally lift all boats and affect all of us. But I think most people tune this out. Most people sort of again, they in their itch to move forward, and they're turning their back on the pandemic, and unfortunately on the millions of people who are suffering from it. And yes, some people sort of emerge unscathed from this pandemic, and good for them. They are at risk of actually developing long COVID if they continue to be reinfected. There are millions other people who are left behind and who are suffering from long COVID with no treatment. So it's and the argument here is that addressing the challenge of long COVID is not only a moral imperative. It's not only the right thing to do, not to turn our back on the millions of people in the US, millions of people in Canada, millions of people around the world who are affected severely by long COVID. It's not only the right thing to do, it's not only the moral imperative, it's also an economic imperative. That because it's precisely because what you were mentioning in the question, it's going to affect healthcare system, economy, labor participation, and literally every facet of our lives. So addressing it is both a moral and an economic imperative.
I 100% agree. And in normalizing this, you're not saying that we shouldn't prevent people from getting COVID. I remember you saying from the US Senate committee, we don't have long COVID if we don't have COVID infection, right? How can we prevent this? Because when we hear, I think when the public hears physicians or scientists talking about COVID, they just, the narrative that I think is in their minds is that, oh, these people just want people to get vaccinated. But that's not it. Is we don't want you to get COVID. Right?
Correct. So the best way to prevent long COVID is to prevent COVID in the first place. That's really, and yes, absolutely correct. You don't have long COVID without COVID. So if you go back and rewind, I told senators in the U.S. Senate, like, if you rewind to 2018, have you heard about long COVID? Nobody said that. Yes. No. So I take it as a no. I asked all senators. They were around me, all of them, all 12 of them, and I said, like, hey, have you heard of long COVID before the pandemic? No, it didn't exist in 2018. It didn't exist in 2017. There's no long COVID without COVID. Long COVID is only a consequence of COVID-19. So it goes without saying that one of the key pillars of reducing the risk of long COVID or preventing long COVID is actually preventing COVID in the first place. And that can happen, it needs a multi-pronged approach. I think masking is one thing, but also making sure that we have air ventilation and filtration systems to clean indoor air is really key. Making sure that we have vaccines that induce strong mucosal immunity, either oral or intranasal vaccines that induce strong mucosal immunity to block infection, so people don't have to mask is another thing. Making sure that we have pan-coronavirus vaccines. The virus is going to continue to evolve. It's already told us this. It's already been telling us this for 4 years. I'm going to continue to evolve. I'm going to continue to change on you. And every few months, you have a new variant or subvariant, right? So we need vaccine technologies that actually outsmart the virus and outpace the virus. Now our current approach is really we're actually playing catch up. We're reacting to it. It changes to Omicron. We design a vaccine for Omicron. It changes to we're really literally reactive to it, and we need to be more proactive and design vaccine approaches that are more pan-coronavirus vaccine or variant-proof vaccine approaches. And really also importantly, vaccine uptake in the United States this year has been low, and it has been low in a lot of other parts of the world. So basically the public is telling us, I'm sick and tired of having to go and get vaccinated every now and then. So how about we also develop vaccines that have a more durable immunity, so people can get them once every few years and be done with it, right? So our approach to prevention should be multi-pronged and sustainable in the long term. And that should come in the form of, again, better vaccines, mucosal vaccines, air filtration and ventilation systems, which we can do. I mean, we do here, like a lot of buildings have, not a lot, but some buildings have these things. And why can't this be available everywhere, right? And this building and other buildings also are earthquake proof. And when we invest literally billions with a B, billions of dollars to make buildings seismically proof, meaning that they're not going to crumble when an earthquake hits. And guess what? An earthquake hits here every 50 to 100 years, and yes, yet we invest billions of dollars in making these buildings, seismically proof. So when the earth shakes, they're still standing, also bridges and everything else, billions of dollars. Why don't we invest billions of dollars, or actually much, much smaller amount would suffice to upgrade our ventilation and air filtration systems to make sure that our indoor air in schools and public buildings and buildings like this and hospitals are actually clean, so people don't really, don't have to breathe contaminated air that has airborne pathogens like SARS-CoV-2 or other pathogens that could be transmitted in the air. So these are what I think common sense approaches that we should learn from this pandemic, and again, and it would be, I tell people that we already paid the heavy price for this pandemic. Millions of lives lost around the world, and millions more, maybe hundreds of millions actually with long COVID around the world. We already paid the price for this pandemic, so let's learn from it. We already paid the price for this book. We already paid the price for this movie. So this horror show. So might as well learn from it. What a tragedy would be it would be a double tragedy if we pay the price in terms of millions of lives lost and potentially hundreds of millions of people with long COVID around the world and fail to learn from it. And our kids will remember this in 2040 and 2050. They're going to be hit with another pandemic. They're going to be hit with another virus. That virus will produce in its wake a long tail of disability and disease. That's going to be let's say, long virus 2040. And these kids are going to say, oh, you had it all. You actually knew about it then. You could have solved it for us then. You could have actually made us better prepared to actually face the challenges of the virus or the pandemic in 2040. But you failed and you didn't. And as a result, they're going to, history will repeat itself and they will suffer all over again. So solving the puzzle of long COVID is not only important to address, the challenges of people with long COVID, but also important to really help us prepare and be able to navigate the rough waters of future pandemic. It's an investment not only in the health of people now, but also in the health of future generations.
So well said. Thank you, Dr. Al-Aly, so much for taking the time to educate us more about this disease and about the research that you're doing to help thousands, actually millions of people now who do have long COVID, and for touching there on the importance of prevention, that there's actually a lot that we can do to protect ourselves and to protect future generations, right, from the long-term impacts.
Absolutely.
Yeah. Thank you for all you're doing. We just really support all your work, and I really hope you do get the funding that you're looking for to do these RCTs, so we can come back and maybe have you on again and say, we do have a treatment for long COVID, right? So absolutely, I'm definitely looking forward to that day where we can do these trials and develop treatment or test treatment that hopefully they work and be able to offer them to patients. Again, thank you for having me. Really was delighted to be on your show, and thank you for the opportunity to talk about long COVID to your audience. Thank you so much.